Chapter 9, Articulation. So the purpose of this chapter is to identify articulations, classify joints based on structure and function. So we're going to introduce you to various types of joints in the body, discuss how they're classified, and learn the different types of movements that can be carried out because of those specific joints. Articulations. Let's first define what an articulation is. We have used this word again and again when we went through the skeletal system and identifying all the bones and all their landmarks, and we put a broad stroke definition to this word. So articulations is essentially a joint. Its function is to hold the skeleton together and allow for movement. When skeletal muscles contract, it pulls on bones and allows the bones to function as a lever. So this is an important distinction. When we talk about muscle and muscle contractions and how it moves bones, we're going to see that muscles will pull, never push. So again, it pulls on bones, allowing the bones to function as a lever system. A fulcrum is another name for a joint. The degree of movement depends on the structure of the joint. Some are freely movable, while some are slightly movable, and then some don't move at all. So what you have here is a hyperlink that will bring you to a slideshow to run an animation through the classification of joints. Remember, you must have internet and be in slideshow mode in order to run this animation. We will go through this classification on the next few slides. So when we talk about joints, we deal with a similar type of nomenclature like we did with tissues, 2 words. So we're going to name joints based on function and structure. Function will come first, followed by its structure. Now, there are only 3 options for function. Either the joint allows no movement, it could give a little movement, or it can be freely movable. So joints that give no movement, we're going to call them a synarthrotic joint or synarthrosis. Examples would be sutures, like your cranial bones, or agamphosis, which are the joints that form your teeth. The next joint is an amphiarthrotic joint or amphiarthrosis. These allow little movement, so they give a little bit. So if you think about where those 2 pubic bones meet and the pubic symphysis, that fibrocartilaginous pad, gives a little bit to move, especially during childbirth. Those intervertebral discs between each of those vertebrae, again, fibrocartilaginous pad, gives a little. That's why you could bend and move your spine, flex your spine. The next and most numerous joint in the body are diarthrotic joints. These are also known as diarthroses. They are freely movable, things like your elbow, your hip, your shoulder, your knee, your ankle, your wrist. All these freely movable joints make up the majority of joints, again, in your body. Classification according to structure. So now that we just finished function, let's classify our joints based on their structure. So again, we do one of 3 options, but some of these 3 options have subsets. For example, our first is fibrous. So the structure would be a fibrous structure. We have 3 options. The first being a suture. So you should recognize this word like the lambdoidal suture or the coronal suture or sagittal suture, right? So these are held in place by dense fibrous connective tissue. So if I were to ask you and say classify this suture, and I pointed to the coronal sutures, classify this suture based on function and structure, you would say to yourself, okay, it's an immovable joint and it is a fibrous and subset suture. So if we had to classify it, we'd say it is a synarthrotic fibrous suture. Now there is a cheat to this. Remember, we're going to keep it 2-word nomenclature. You can say synarthrotic for immovable and then go directly to suture. By saying suture, you're telling me that you know it's fibrous. What you cannot do is say a synarthrotic fibrous joint, because which of these 3 fibrous joints are you speaking of? You have to be a little more specific here. The next subset under fibrous is a syndesmosis. So this has more dense fibrous connective tissue than a suture does. For example, your gomphosis joint. So all your teeth, those periodontal ligaments holding that tooth in place, is again an immovable joint. So if I pointed to the tooth and say classify this joint based on structure and function, you would say a synarthrotic syndesmosis. The last is a little more obscure. We don't really cover this in class, but we are going to explain because it does exist. Interosseous membrane. So remember, inter means between. So we break apart our words, between osseous bone. So if we go between 2 parallel bones, like the tibia, fibula, radius, and ulna, we have these broad sheets of dense fibrous connective tissue. Basically, what this does is it allows for some movement. So it allows to disperse weight evenly between two proportionately or non-proportionally shaped bones. So if you look at the radius and the ulna, you see that the ulna is much more thinner and smaller as the radius is. But in order to protect the integrity of these bones, especially if you're doing like a handstand or applying pressure, you don't break one, the smaller one, the ulna, off the radius, is that these interosseous membranes allow for an even distribution of weight between those two bones. The next structure is a cartilaginous structure. So as its name implies, we're looking for something that's going to be made up of cartilage. So the first is a synchondrosis. So we break apart a word again, synchondrosis with cartilage. We find anything that is connecting to hyaline cartilage, or connecting using hyaline cartilage. For example, rib 1 to the sternum. This is a unique rib. This provides no movement. This is going to connect to respiratory muscles like the scalenes that are going to help elevate the rib cage during breathing. So if we had to classify rib 1 to the sternum or any epiphyseal plate based on function and structure, if I pointed to the joint of rib 1 to the sternum specifically and said classify this based on function and structure, you would say it's an immovable cartilaginous synchondrosis. So what was our immovable word again? Synarthrotic. So it's a synarthrotic cartilaginous synchondrosis. But again, remember our cheat. We can say a synarthrotic synchondrosis because you're telling me you already know it's cartilaginous. Next is a symphysis. Now this should be easy because we did the pubic symphysis, those two pubic bones. It is a fibrocartilaginous pad. It gives some movement. So right away you should be thinking function, some movement, slight movement, amphiarthrotic. So if I point to that pubic symphysis and say classify this joint based on structure and function, you'd be able to say it is an amphiarthrotic cartilaginous symphysis. But again, to go through our cheat, we would say an amphiarthrotic symphysis. Next is synovial, and we have a bunch of subsets for synovial. We have ball and socket, hinge, gliding, or plane, interchangeable. We have condyloid, pivots, and lastly, saddles. Now to define synovial joints, they are articular cartilage on the ends of our long bones with a synovial cavity between articulating bones, surrounded by accessory structures like ligaments. They are freely movable, so we have this variety of range of motion, which we'll cover a little later. Things like your hip, your knee, your elbow, or your shoulder. Let's now put it to slide our fibrous joint. It lacks a synovial cavity, so different from a synovial joint. Articulating bones are held together with dense fibrous connective tissue. They usually provide little or no movement, so synarthrotic or amphiarthrotic joints. Our types, sutures, syndesmosis, and interosseous membranes. Here's an example of a fibrous joint. Look at the suture. You can see that connective tissue, that sutural ligament holding that squamous suture together. On the left is an example of an interosseous membrane between the tibia and the fibula. Whereas on the right, we have all those periodontal ligaments, so all those periodontal ligaments forming that gomphosis. Next is our cartilaginous joints. Again, these also, because they're not a synovial joint, lack a synovial cavity. Articulating bones are held together with cartilage connective tissue. They are going to provide little to no movement. Types are synchondrosis and symphysis. Here are some examples of cartilaginous joints. On the lower right, we have our pubic symphysis, so that fibrocartilaginous pad that connects the two pubic bones, and our epiphyseal plates for synchondrosis. That brings us to our synovial joints. Synovial joints are surrounded by a fibrous articular capsule. A synovial membrane, mostly loose connective tissue, lines the wall of the articular capsule. The membrane does not cover the surface of the articulating bones. Instead, it surrounds them. Articular cartilage covers the bony surfaces that form a joint. The cartilage is very slick and smooth, which protects the joint from high friction due to that movement, and it's very similar to hyaline cartilage. Which brings us to the actual fluid in that synovial joint, in that synovial cavity. So the function of the synovial fluid. So the synovial membrane produces this fluid that lubricates and reduces friction within the joint. It is almost like a maple syrup type of consistency. It's similar to interstitial fluid, but with high levels of proteoglycans. So these proteoglycans is what makes it syrupy. Now when you push a joint past its means, fluid spreads. The fluid spreads, which allows for shock to be absorbed. Now, when the joints are not active, the cartilage takes up fluid, which keeps the cartilage moist. The connective tissue within the membrane allow for nutrient distribution because the connective tissue is vascular. Now we can look at examples. So again, here's that move it or lose it scenario. As long as you keep moving joints, they will continue to lubricate that joint by producing this synovial fluid. When you stop moving, the joint physically dries out. Synovial fluid is not replaced and can increase the chance of friction building within that joint cavity. Now the next thing is something called cavitation. So this is where you essentially crack your knuckle. So if you were to do that now, all that popping you hear does actually no pathology. It's not bad, it's just meh, right? Not good, not bad, does nothing. What's happening? So you're stretching those joint cavities beyond their means, which is pushing all that synovial fluid to the outside margins of that joint cavity around the bones. The gases, specifically nitrogen, that's dissolved in there is dissociated into bubbles, and those bubbles pop. That's called cavitation. That's what you hear when you crack your knuckles. Now, if you cracked your knuckles just now, because you probably tried it, you realize that if you try to crack them again, it won't happen. You already popped those little nitrogen bubbles. So what has to happen? That nitrogen has to dissolve back into solution. It takes about 20 minutes. So in about 20 minutes, you'll be able to recavitate, re-crack your knuckles, and repeat this process again and again. Let's look at some accessory structures of synovial joints, things that stabilize, protect, and help decrease damage to surrounding tissue. Our first is going to be a bursa. These are little pockets of synovial fluid within connective tissue. They're like little balloons filled with fluid. They're present where tendons and ligaments rub against other tissues. What this does is kind of spaces, they're spacers. They space apart bones, muscles, tendons, and ligaments, again decreasing friction. Next are going to be fat pads. They are pockets of adipose tissue covered with synovial membrane. They are superficial to the joint cavity and function as a protective layer, so they protect that cavity. Fibrocartilaginous pads are third. Things like the menisci of the knee, so if you've ever heard of anybody tearing or rupturing a meniscus, medial or lateral meniscus, these are little fibrocartilaginous pads that help to space bones and prevent them from rubbing against each other. The fourth are ligaments, so this is going to connect bone to bone. So if you think again to your knee, these are common ligaments that people tear from sport-related injuries like your ACL or MCL or PCL, anterior cruciate ligament, posterior cruciate ligament, medial collateral ligament. So again, these ligaments connecting bone to bone, stabilizing the knee. And lastly, fifth, we have our tendons, which connect muscle to bone. Let's look at a picture to explain what we just talked about, the structure of a synovial joint. So what you're looking at here is a finger, and we're taking a nice little frontal cut to look at the joint cavity. So what do you see? You see the two articulating bones here, 1 and 2. And then you see the actual fibrous membrane that forms and surrounds and makes up that joint cavity. Now, the yellow is the space, so this is that joint cavity that's contained or holding that synovial fluid, that proteoglycan syrupy synovial fluid. The blue is the articular cartilage found at the ends of bones. Now, the red here on both sides is the synovial membrane, that highly vascularized membrane that is making and recycling those nutrients in the synovial fluid. Now, as we continue with our lecture, we're going to discuss all the factors that stabilize synovial joints. So we talked about some of the structures, but let's look at some of the factors. So this varies depending on the joint. So we have good joints, good bony fits, bad bony fits. So based on what you have learned about the skeleton, why is the hip more stable than the shoulder? What impact does this have on joint and vulnerability? So if you remember before, we see this common trend in biology, especially the human body, where we give a little to get a little, right? So again, kind of like we introduced this before with our skeletal lecture, but in order to gain flexibility, we're going to give up stability. So here's that give and take. So if we want low flexibility, we get high stability. High flexibility gives us low stability. So you think about the shoulder versus the hip. So some of these factors are the bony fit, the amount of articular cartilage, the size of the muscles and tendons that help stabilize and lock that joint, the amount of intracapsular or extracapsular ligaments, so the ligaments within the capsule or around the capsule, and then also the tension in tendons attached to those articulating bones. Now what happens when all those reinforcing structures fail? So both are more common in people that are double jointed, weakly stabilized joints. So when we use that word double jointed, doesn't mean that people have two joints, it just means that they have loose tendons and ligaments. So what happens in these situations? We get a couple things that could occur. Number one, a dislocation. So its clinical name is a luxation. This is where the articulating bones are separated, and this is dangerous because it can cause damage to surrounding tissues, muscles, blood vessels specifically, and nerves. Next is a partial dislocation. It's called the subluxation. This is less severe because less tissue is damaged and the bones are not fully separated or dislocated. Types of movements for a synovial joint. So table 9.1 goes through different movements that occur with our different joints. So for example, gliding. Think about your wrist joints, right? All those 8 bones in your wrist. The majority of them between those carpal bones are gliding. So they move on a triaxial plane all day long. Movement of relatively flat bones, back and forth, side to side, all over another. Little change in angle between the bones. So it's just gliding. Next for angular. So we increase or decrease the angle between bones, like flexion or extension. Right? So flex your forearm, bring your hand to your shoulder, flexion, extend it, move it away. So flexion, decrease in angle between articulating bones, whereas extension is an increase in angle. And then lateral flexion, movement of the trunk in a frontal plane. Then if we take and hyperextend, so extend beyond anatomical position, we can hyperextend your head. So if you were to look up at the ceiling, this is a hyperextension. Abduction, adduction, a movement of bone away from the midline. Adduction is movement of bone towards midline. So if you take your hand, open your fingers, that is abduction. Now if you put your fingers together, you're adding them together, this is adduction. Circumduction, straighten out your arm, make a big circle, this is circumduction. Flexion, abduction, extension, adduction, and rotation in succession. Next rotation, you can take your head and move it left and right. This is rotation around the longitudinal axis. We have special directions on specific joints. Things like elevation, depression. So open your mouth versus closing your mouth. We can depress the mandible by opening it and then elevate it by closing it. Push your lower jaw out, away from your mouth. This is protraction. Retraction, pull it in. Inversion, eversion, like your foot. Turn the sole of your foot medially. This is inversion. Turn it laterally, eversion. Dorsiflexion versus plantar flexion. Pull your toes up. Dorsiflexion, point your toes down. Plantar flexion. Supination versus pronation. We covered these with basic terms like turning your hands outward, palms up in the correct anatomical position is supination. Turn your palms over, pronation. And then opposition, take your thumb and touch each of your fingertips on the same hand, opposition. So now let's look at some examples of movements of synovial joints. So here we see our carpal bones just gliding along a plane. All those types of movements that we talked about, flexion, extension, hyperextension, you can look at this map and then practice moving your bones in different directions, contracting muscle to get these similar actions. So continued with types of motions, you can practice these movements on your own. And some more circumduction and different types of rotations. And you can continue practicing with things like elevation, depression, protraction, retraction, dorsiflexion, plantar flexion, inversion, eversion, etc. So this is a nice table for you to review and summarize the structural and functional classification of joints. So you can see on the left we have our structural classification here, whereas on the right we have our functional classification. So a nice review of everything we've talked about. Adding movements. So you can see the synovial joints are 6 synovial joints, plane, hinge, pivot, condylate, saddle, and ball and socket that we outlined before, and what type of action, description, and example action you get, and where we see it. Now we can elaborate on types of movements as synovial joints. Now, while this is not very important for us to master right now, we just want to explain how they work. So, plane joints between the navicular and the second and third cuneiforms of the tarsus of the foot is a biaxial or triaxial joint. They are moving on a plane, up, down, left, and right, or twisting a little bit, giving us a little rotation. Our hinge joint is uniaxial, or elbow, right? Think about your elbow. You get flexion and extension only, so we pair like motions. So this is a uniaxial joint. Whereas if you pronate and supinate your palm, this gives us another type of uniaxial joint, right? Because we're only going in one direction. We're either supinating or pronating. So it doesn't give us multiple different planar directions. Whereas if you go to the scaphoid and the lunate, where it connects to the radius and the ulna, this is a biaxial joint. So we're getting two different planes of action here. Our one and only saddle in our body is the thumb. So this gives us a biaxial action as well. And if we look at our hip for multiaxial or triaxial, we get movement on all three planes. So putting it all together, how do different synovial joints allow for different movements? We start with ball and socket, like the hip or shoulder. It's multiaxial movement on three planes. Flexion, extension, abduction, adduction, and rotational movement are our three types that we see. Hinge, elbow, uniaxial, ankle, uniaxial. Now the knee is a little weird because we do get flexion extension, but because we're able to get a little bit of rotation, rotational movement to lock and unlock the knee, we call it a modified hinge or biaxial. We also see this in our jaws, another modified hinge. Pivot joints like C1 and C2, so if you turn your head left and right, or our proximal and distal radius and ulna, we're dealing with these uniaxial type pivots. Our condyloid joints, like our radiocarpal joint, metacarpal and metatarsals with primary phalanx 2 and 5, occipital bone with C1, so taking your head, rocking yes, and giving some lateral and medial flexion is a biaxial joint. Gliding, tarsals, carpals and metacarpals, rib 2 through 7. Remember, rib 1 was that special immovable rib. Rib 2 through 7 with the sternum. Tarsals and metatarsals between articular facets on thoracic vertebra and ribs between the superior and inferior articulating surfaces with the vertebra are types of gliding joints. Saddle, again, that thumb is a biaxial joint. So the next few slides take those joints that we just talked about and put it to a mechanical-like picture. So, for example, the clavicle where it meets the manubrium is a gliding joint. You can see how it moves on multiple angles. And then here's that hinge, flexion and extension. This is what it looks mechanically. That atlo-occipital joint or atlo-axial joint where we get that no motion, where we get rotation, so this way and this way. And then keep going with our ellipsoid joints, where we get the scaphoid bone with the radius and ulna. They're also called condyloid, right? So we talked about condyloid joints, our saddle joints, and balls and sockets. Now we could focus more on that give and take that we had alluded to before. Why is the knee a bad bony fit? So let's look at the bones. Flat tibia, large femoral condyles. They don't fit together. They rely on these accessory structures to stabilize them, like the menisci, fat pads, bursa, these tons of ligaments and tendons that are going to help stabilize this problem. Now look at our anterior cruciate ligament and our posterior cruciate ligament. They prevent anterior movement of the femur, whereas the PCL prevents posterior movement of the femur. This keeps the femoral and tibial condyles aligned, whereas the LCL and MCL give stabilization to their medial and respective sides. So the lateral collateral gives lateral stabilization and the medial collateral gives medial stabilization. Look at this picture. You can identify all the joints and in all the ligaments and tendons and structures and muscles and bursas and fat pads. But in lab, we're really going to focus this with the model. But look at this hodgepodge, this mess of stuff. All these twisting, crossing, interwinding, swirling structures that are here to help stabilize this bad bony fit, which is why we see a lot of knee injuries in sport-related activities, especially contact sports like soccer, football, lacrosse, etc. Here's a cadaveric look at some of these ligaments that cross between the femur and the tibia, specifically those ACLs and PCLs. Right, here's that ACL and that PCL. Look how small ligaments, small muscles, small tendons, small accessory structures. So we're giving up strength, stability, and the sacrifice is we're getting range of motion, a lot of flexibility here. So to summarize why the knee has problems, well, because obviously it's a bad bony fit, so when stabilizing structures are damaged, the joint can become severely compromised. So an example would be like something called the terrible triad. So 3 things are going to get destroyed here. So it's a hit to the lateral surface of the leg will drive the knee medially and result in tearing of the ACL, medial meniscus, and the MCL. Again, this can put an athlete out or a person out of commission for about a year and change. Injured cartilage can restrict movement in the joint as it gets trapped, popping in and out of position. Torn ligaments are poor healing and difficult to repair surgically. So we have a lot of knee problems. So you see a lot of ACL joint repair, a lot of knee repairs. Now let's look at a good bony fit. The elbow. Why is it a good bony fit? So the notch on the ulna grabs the trochlea in this plier-like grip. It's like a can opener. Grabs on and doesn't like to let go. With flexion, the small radial head sits in the radial fossa and articulates with the capitulum of the humerus. With flexion, the coronoid process of the ulna sits in the coronoid fossa and articulates with the trochlea of the humerus. With extension, the olecranon moves into the olecranon fossa on the posterior humerus, and you have these nice ligaments that are going to help reinforce the joint. So look at this picture. Nice, tight, bony, plier-like grip. That's why we don't see very many elbow injuries. Well, not that they don't occur, but not as frequent as knee injuries. But again, look, what are we giving up? We're getting strength, we're giving up flexibility. This is a uniaxial joint. We're only getting flexion and extension, nothing else. Next is the shoulder. Another problem issue for sports and high sport-related injuries here. Why? Why is this vulnerable, right? Why is this a weak joint? But look what we gain. Flexibility. The humeral head rests in the glenoid fossa and is not a deep ball and socket, not like the hip. That is a deep acetabulum, deep ball and socket. The scapula is only held by back muscles, these fixators, and the pectoral girdle is only connected to the exoskeleton at the sternoclavicular joint, this little clavicle holding it in. It also has less cartilage, smaller tendons, smaller ligaments, versus the ball and socket of the hip that has larger tendons, larger ligaments holding everything in. So frequent injuries are to the clavicle in contact sports, things like a separated shoulder, where we separate the acromial clavicular joints, where the acromion and the clavicle join together. So again, here's our sacrifice. Small tendons and ligaments, small muscles holding this in place, reinforcing the joint. We get great flexibility, but what the sacrifice is diminished stability or strength. Now the hip. The hip's a good bony fit. Now we kind of talked about it when we compared it to the shoulder, but that deep acetabulum firmly holds the head of the femur in place. Large cartilage, a lot of it, strong big ligaments, and large tendons are going to help reinforce and stabilize this joint. So it's very, very firmly attached to the axial skeleton via our sacroiliac joint, and then those at the acetabulum. Now, think of it like this. Let's look at our next slide. We look at these large fat pads, these large deep acetabulum, that deep ball and socket. It really is going to anchor and hold that in. And then even on the next slide, look at these large ligaments and tendons holding this bone in like a tornado swirling around. We'll erase it so you can really see the swirling pattern, swirling around to hold and anchor this bone in place. But look at the sacrifice. We're gaining strength and stability so we could stand and walk all day, so we gain stability and strength. But where's the sacrifice? The sacrifice is in range of motion or flexibility, or flexibility. Now we're going to end our conversation with a couple more examples of articulations, like our intervertebral, and then look at some pathologies that can occur when we damage these joints. So intervertebral articulations, they are gliding joints, so superior and inferior articulating surfaces, right? We get more gliding joints of the thoracic vertebra with the heads and tubercles of the ribs. Our vertebral bodies form symphyseal joints, which are cushioned by intervertebral discs. So again, a symphysis, these fibrocartilaginous pads. Now those pads are made up of an outer annulus fibrosus and an inner nucleus pulposus. Now damage to these two regions can cause some pathology. Now we stabilize these structures with many different ligaments that we're not really going to focus in this class, but there are multiple ligaments running the length of the vertebral column stabilizing this structure. Let's take a look at a picture. So you can see a bunch of these ligaments, and again, don't worry about their names, but you can see how they are helping to stabilize these bones. What we really want to pay attention to is this. These intervertebral pads. Look at the nucleus pulposus, the yellow on the inside, and the annulus fibrosus on the outside. Now let's talk some pathologies. What happens when we get older and our joints, our articulations? So as we age, the cumulative wear and tear results in a loss of joint function and mobility. As a result, we can lead to inflammation, which can develop, and this is typically painful and chronic, meaning long-lasting. Now, again, regular exercise, anti-inflammatory agents, and physical therapy can help this. For severe situations, surgical procedures can realign or even replace arthritic, worn-down joints. Now, treatment. How do we treat this? Treatment is important because when mobility declines, the circulation of synovial fluid is compromised. So, here we go again with that move it or lose it scenario. Continued passive motion helps to encourage repair of the tissue because it improves synovial fluid circulation. With age, bone mass decreases and fracture risk increases, even in people without osteoporosis. Let's look at what happens when we damage the intervertebral discs. So we have two scenarios. We have a slip disc or a herniated disc. Now, some people, even at college age, suffer from these conditions, or your parents or grandparents might suffer from this, and this can occur, and two different things can happen. So, what is a slip disc? A slip disc is a swelling of the annulus fibrosus. Now, what happens is that swelling can push in on the tunnel that your spinal nerves and nerves move through and cause some pain. Now, the worst is a herniated disc. So the annulus fibrosus gets pushed to the side because of this nucleus pulposus. So this nucleus pulposus pushes its way through the annulus fibrosus, pushing on that spinal nerve. And this could cause shooting, excruciating pain, especially if it occurs in the lumbar level of our spinal cord, which it usually does because those are a weight-bearing vertebra. Pain down the legs, the anterior lateral aspect, inner aspects, all the way down to the foot could be excruciatingly painful. So let's look at disc damage. Again, that slip disc, to put it to words, the nucleus pulposus enters into the annulus fibrosus, which can weaken the joint between adjacent vertebral bodies. A herniated disc, the nucleus pulposus enters into the annulus fibrosus and passes through it. As it exits the outer core, it can then enter the intervertebral foramen and compresses that spinal nerve. That's what causes the excruciatingly painful sensation down your back and into your leg. So for our last slide, let's summate factors affecting contact and range of motions at synovial joints. So number 1, structure and shape of the articulating bones. 2, strength and tautness of those joint ligaments. 3, arrangement and tension of the muscles. 4, contact of soft parts. 5, hormones. Remember, hormones play a role in bone growth, also play a role in maintaining the health of our joints. And disuse. So again, our move it or lose it scenario.